Good morning, everybody. I'd like to welcome you all to the Joint Oireachtas Health Committee. Before we start, just a few housekeeping matters. Presence in Leinster House, I'd like to advise members of the constitutional requirement that members must be physically present within the confines of the Leinster House complex in order to participate in public meetings. I will not permit a member to participate where not adhering to this constitutional requirement. Therefore, a member who attempts to participate from outside the precinct will be asked to leave the meeting. In this regard, I would ask any members participating via Teams that prior to making a contribution to the meeting that you would confirm during the grounds of Leinster House campus. Utterances by members. Members are reminded of the long-standing parliamentary practice that you should not criticise or make charge against any person or entity by name or in such a way to make him, her or it identifiable or otherwise engage in speech that would be regarded as damaging to the good name of a person or entity. Therefore, if your statements are potentially defamatory in relation to an identifiable person or entity, you would be directed to discontinue your remarks. It is imperative that you comply with any such direction. Today, the committee will consider the treatment of children with hip dysplasia and scoliosis and related matters. To commence the committee's considerations of this matter, I'd like to welcome from Children's Health Ireland, Lucy Nugent, the Chief Executive, very welcome, Dr. Ike Okafor, the Clinical Director, Eilish Hardiman, Strategic Programme Director, Dr. Alan Goodman, the Chief Medical Officer, David Moore, the Head of the Spinal Services Management Unit. From the HSE, Kate White, Regional Executive Officer of the HSE Dublin and Midlands, Dr. Colin Henry, the Chief Clinical Officer, Anne-Marie Hoey, the Chief People Officer, and from the Department of Health, Tracy Conroy, the Assistant Secretary, and Rachel Canahan, the Chief Nursing Officer. I think it's fair to say that the matters before us are very serious. What's been revealed in the various reports and via the media is deeply concerning, I know to committee members, but also to citizens across the country. Before today's meeting, we had asked Children's Health Ireland to provide us with a publication of the internal investigation, which hasn't happened. I think that's somewhat disappointing. We'd like to have seen that before today's meeting. And I think also to say that some of the replies that we've had to parliamentary questions have been unsatisfactory. So I expect that today we'll have full and frank answers to some of those questions. To commence our consideration of these matters, I invite Ms. Nugent to make the opening remarks on behalf of Children's Health Ireland.
Good morning. I want to thank the committee for the opportunity to address you today. My name is Lucy Nugent and I'm the Chief Executive of Children's Health Ireland, and I'm joined by my colleagues, as the Chair previously said. I'm pleased to be here before you today representing Children's Health Ireland, and I will endeavour to answer your questions to the best of my ability. I joined as Chief Executive 5 months ago tomorrow. As I said to your colleagues on the Public Accounts Committee, I want to express how proud I am of our almost 5,000 staff who work diligently at the front line of paediatric healthcare provision in CHI at Temple Street, Crumlin, Tala, and at our Urgent Care Centre at Conley. I began my career as a nurse in Temple Street Children's University Hospital, and I appreciate the pressures and demands placed on our people on a 24-hour, 7 days a week basis, but also how rewarding our jobs are. Last year, CHI treated more than 148,000 children who attended our emergency departments. Almost 29,000 children underwent day case procedures, more than 17,000 children underwent theatre procedures, and almost 29,000 children and young people had an inpatient stay with us. Exceptional care was delivered to these children despite being in old and not fit for purpose buildings. We continue to lead on paediatric research and innovation on an international stage because our children and our young people do deserve the best that medicine and science can offer. We don't just provide healthcare, we provide support for children and families when they are at the most vulnerable. And we respect that that is a privilege. We are a place of healing, a source of comfort, and a community with a relentless dedication to paediatric healthcare. A message that is often lost, and especially in the current climate. We want every patient and family who we meet to feel safe and cared for. But we need to do better. Despite all this good work, I am very aware of the impact of the last several years, months and weeks, where revelations relating to our culture, governance and practices have led to great pain being inflicted upon some of those who are in our care. I say to you, I say to the children and families impacted and to the Irish people that I am sorry. I'm sorry on behalf of the management of Children's Health Ireland, and I'm sorry on behalf of the entire organisation. I am very aware of the various issues that my organisation is grappling with, and I will speak to each of these issues during the course of this morning. I know they have an enormously worrying impact on parents around the country and whether they can place their trust in us. We want the best possible outcome for our children when they go into hospital and when they leave hospital. When that not happen, children have failed and trust is broken. Our mission statement that we in CHI aim to promote and provide child-centred, research-led, learning-informed healthcare to the highest standards of safety and excellence. On occasions, we have failed to do that. As the new CEO of this organisation, I am determined to ensure we can restore trust and faith in our National Paediatric Service. In relation to the challenges of spinal surgery, as stated just a couple of weeks ago at the Public Accounts Committee, I would like to acknowledge and give full recognition to the families who were impacted by the recent HICWA report relating to the use of unauthorised springs in 3 children. What happened should not have happened, and children should have been protected from harm. We are deeply and unreservedly sorry to those families. We do not underestimate the impact that this has had and is having on the families affected, and the distress that it has caused to all patients and families in the spinal service. The HICWA review found that while corporate and clinical governance arrangements were in place in Children's Health Ireland, there were unclear lines of reporting and accountability to ensure the safe introduction and use of new surgical implants and implantable medical devices. It was found that supporting policies and procedures were either not in place, not fit for purpose, or were not followed. CHI has since introduced robust policies and processes with training and awareness for staff ongoing. In relation to the CHI Spinal Surgery Management Unit, which was established in 2024, led by my colleague here, Mr. David Moore, this unit's aim is to build a safe and world-class spinal service which treats children and young people in a timely and patient-centred way. Between January and May 2025, 254 procedures have been added to the spinal surgery waitlist. This is compared to 193 procedures added for the same period in 2024. And while we are doing more spinal surgeries this year, 210 to date, we are also seeing more outpatients and adding more procedures to the waiting list. But I recognise that these are just not numbers. These are children and young people. The list is constantly changing as children and young people have their surgeries and come off the list. New patients are added. But important progress is being made every month. The Spinal Surgery Management Unit has implemented initiatives which have reduced the waiting time, for example, for outpatients by 40%. We acknowledge that waiting times for patients are still too long, and we continue to work to reduce the length of time that patients are waiting for appointments. In relation to the report on developmental dysplasia of the hip, it is in the public domain, having been published by CHI on May 23rd. I recognise the worry it has caused many more patients. The audit reviewed 147 random and anonymous cases across the 3 hospitals, based on criteria that have been retrospectively applied for the purpose of the audit, and it found thresholds for recommending pelvic osteotomy procedures did vary between CHI at Crumlin, CHI at Temple Street and the National Orthopaedic Hospital in Kappa. Children who had surgery at CHI at Crumlin were found to have been appropriately selected for surgery based on the current international standards used by the auditor. A proportion of children, in the opinion of the auditor, did not meet the threshold for surgery based on the criteria used for the audit. Regrettably, the audit identified one case from the review sample where a child experienced complications due to the surgical approach recommended to them. This family has been contacted and supported through an open disclosure process. The audit made a number of recommendations which are fully accepted and will be implemented across CHI. All families have been sent a letter which details if their child was part of the audit and what their next steps will be. The multidisciplinary team review clinics have started. This is a once-off review to assess complications only and determine the current clinical state of each patient. After this, patients entered the recommended normal follow-up process. To date, 105 appointments have been offered with 60 patients seen in CHI and a further number of patients seen in Kappa. We are arranging these clinics as quickly as possible and hope to have seen all children within 6 months. Multidisciplinary team meetings have started to include all surgeons cross-site, so any child who is listed for a hip surgery with CHI is now discussed at this MDT prior to surgery, so that all children and young people who come to CHI for care will receive the same standard and care across our hospitals. This MDT is currently supported by 2 international experts. Families will be involved in a thorough and transparent discussion of decision-making, including risks and benefits, in order to make informed decisions with and for their child. Any complications identified during the follow-up reviews will be acknowledged, discussed with families and appropriate action taken. The purpose of this review is to ensure patients are doing well following surgery, and should any concerns be identified during this appointment, they will be discussed along with any recommended course of action. The care and well-being of our children is our absolute priority in Children's Health Ireland, and I'm sorry that impacted families were not offered one consistent and excellent standard of care across our DDH service. I do not underestimate the stress and anxiety that families are rightfully feeling throughout this audit process. And to the one family in particular whose child experienced complications during their care in Children's Health Ireland, I extend my heartfelt apology. I would like to give my assurance to all families affected that they will be directly supported and are being contacted with follow-up information and the next steps. We are currently standardising care across all CHI sites, so all children receive the same high-quality treatment no matter where they are seen. Also, it's important that we now act swiftly to review DDH patients to enable us to answer outstanding questions raised by this audit. This will be done openly and transparently. The independent HSE review will determine if surgery was required and will assess the appropriateness of the original decision-making. And this review is in development by my HSE colleagues. We have had dedicated supports in place for families who wish to contact us about this report since March of this year. And every family has been responded to in a timely manner, although I do accept that families want more detailed information and that it is a very stressful time for them. As with the issue that was the subject of the HIC report, I can assure the committee and the public of my absolute priority as a CEO to ensure robust governance and processes in CHI, as well as fostering a caring, open and supportive culture for children, families and staff. In relation to the recent unpublished report, the members will be aware of the recent internal report relating to the number of interpersonal and process matters which have been the subject of much media attention. In the first instance, I want to apologise for the fact that I as CEO and CHI as an organisation are not at liberty to publish this report. It is not in any way our intention to hide the truth or to hide behind legalities to avoid disclosure. A redacted or pseudonymised version of the report was considered, but it would not make sense to those who have not seen the leaked confidential report. In addition, the CHI board and executive team wanted to inform the public of what actions have been taken. It is simply our legal duty not to publish the report, regardless of what's in the media. I hope the committee notes that we have provided with a summary of the report which ensures compliance with our legal advice while at the same time providing as much detail as possible relating to the report's contents and, importantly, the action that was taken on the foot of this internal examination. We take our accountability to the public and families extremely seriously. We are committed to learning, improving and ensuring that every child who comes through our doors receives the highest standard of care. Our patients and their families are at the heart of everything we do, and that must remain our central focus. And whilst the myriad of issues that I have spoken of are naturally of the greatest concern to members of the committee, we should not allow today's interaction to go by without referencing the fact that we will soon be moving into the new Children's Hospital. As expressed by my consultant colleagues in a recent letter to the Irish Times, this project is the culmination of decades of work and hope for what we can deliver for children. It represents a transformative opportunity to deliver world-class paediatric care, and we are focused on building a positive, inclusive and forward-looking culture as the one team, working together for the children and the families that we are privileged to serve. We are looking forward to playing our part in ensuring that the new hospital becomes a centre of excellence, defined not just by its infrastructure, but by the spirit of partnership and patient-centred care that underpins everything we do. Once the National Paediatric Hospital Development Board hands over a substantially completed building, CHI will commission the building for it to be operational to the highest international standards. We've been working for many years on integrating services, functions and teams across facilities to become a single organisation with one governance and management structure and one culture, which has been progressed in preparation to move to the new Children's Hospital. And as is obvious, this has not always been easy, but it's been done and it will continue to be done. We will continue to ensure and progress CHI's readiness as an organisation to move into the new hospital, and we will be ready and able to take over this new facility. In line with Launch Care Principles, the national model of care for paediatric healthcare services will ensure a child is treated as close to home as possible. This will put the new hospital at the epicentre of a network of care in collaborative partnership with our colleagues in regional centres to develop comprehensive paediatric care.
We're just over time, so you might give a summary.
Okay, in conclusion, I am new to this job. I wish I was speaking to you in different circumstances. Failings have been identified and we apologise for those failings and repeat that our primary focus is Children's Health Ireland is, at all times, to deliver timely access to quality, safe care to children and young people. But it's a time of reset for us. We are entrusted with the most precious lives, the children and young people across Ireland. I and my colleagues accept and carry this responsibility with us every day. Thank you for taking the time to listen to me, and we are happy to take your questions.
Thank you, Ms Nugent. We'll now move to members. Each member will be allocated a 10-minute slot to ask questions to the witnesses. We will move through the speaking rota as agreed by party size. and move through the rota, continuing as we were. I'd ask members to try to stick to the 10 minutes. I want to ensure that each of the members gets an opportunity to come in. If we stick to the 10 minutes, we'll ensure that all the members have an opportunity to speak today. So begin with, and also just to say, we will be taking a break at around 11 o'clock. So to begin with our first audit for Fianna Fáil, Deputy Daly.
Thank you for coming today. And notwithstanding your comprehensive statement, there is no sense in that statement of the gravity of what has happened to the children in terms of the developmental dysplasia of the hips. There is no sense in your statement of the absolute gravity of what has happened. It is absolutely scandalous. A member of the medical profession, I'm not an orthopaedic surgeon, so I don't pretend to be, but I am a doctor of 40 years standing. Before I came into this job, I would have been minded to defend our profession where it could be defended. But the Thomas audit of the management of developmental dysplasia of hips in children, CHI Temple Street in Crumlin, and the National Orthopaedic Hospital in Kappa is deeply disappointing and unsettling, most especially as it follows on from the use of non-medical grade springs in spinal surgery and CHI. And the HICWA report into the use of non-medical grade springs, we don't have all the answers. The HICWA report, and I quote, there were no overarching CHI. By the way, no one person should be thrown under the bus for this, okay? Notwithstanding, if they have a question to answer about their judgment, about their caseload, about their decision-making, this is not about one surgeon. This is about a whole system failure. And when you talk about moving into CHI, the new hospital, 2.5 billion, it's like having top-of-the-range hardware for your computer and the software is rotten. There's no other way to put it. You know, and I don't think you imparted the sense of realization of the anger, not just to the community of children who were involved. And I do accept the spinal issue might be different from but the hip issue is just inexplicable that in a small city, relatively speaking, in a small country, between 3 orthopaedic hospitals, 3 orthopaedic departments, that you could have such stark divergence of decision-making. Now, the Thomas report has vindicated one department, but the other 2 departments, international experience will show there will be some divergence in the order of 5 to 7% maybe. I stand to be corrected by an orthopaedic specialist in this, but in the order of 60, 70, 80, 90%, there's something absolutely rotten in that department, notwithstanding the work that's done and the good cases that come through, but there is a whole generation of children who have been operated on, who shouldn't have been operated on spurious evidence, without proper audit and without proper governance. Now, I know you're new in the job, Ms. Nugent. Ms. Hardiman, you were there. It looks like under your regime, you were rewarded for substandard management of the hospital. And I'm saying that strongly because all of this happened under your watch. In relation to the HICWA report, and I quote, there were no overarching CHI-wide standardised governance structures. I'm going to keep it to 5 minutes because I'd like you to have your 5 minutes to respond. And supporting policies and procedures in place for the introduction and use of medical devices. This is an astounding finding. In addition, HICWA found what corporate and clinical governance procedures were in place in the CHI group. They were over-complex and difficult to understand for management and staff, both at site-specific hospitals and the overall CHI group. And I've spoken to medical professionals in those hospitals, and they would vindicate that view by HICWA. With the changes from 2019 onwards, there was a loss of experienced management staff at Temple Street, resulting in a breakdown of communication and governance pathways. Whilst there was a number of controls in place, these did not provide adequate safeguards at each stage of the end-to-end process for the introduction and use of springs. I'm going to leave that because I'm going to run out of time. We have the HICWA report. We're waiting the Nagaim report into the practice of one surgeon in relation to the use of non-medical grade springs. It is just incredible that, they came through a whole procurement process, a quality code, and they arrived to a surgeon in the operating theatre, and yet everyone is throwing that surgeon under the bus. And that's management have thrown that surgeon under the bus. He might have exhibited poor judgment. He might have been overworked. He might have had pressure put on him to fulfil waiting lists and to operate more. And that was for him to resist. But management have a serious answers in this. And I don't believe those answers were gotten first thing. I'm running here, so I'm going to give you a chance. On the, we're waiting the Nagaim report, and we will have to wait for that. Just very quickly, in relation to the hips, I've covered that. A lot of the same governance issues, and it would appear that there was a department that was dominated by one or two surgeons who decided what would be best for a child in 15, 16, 20, 30 years and operated on children who shouldn't have been operated on spurious evidence and spurious data. And finally, much has been made about retaining the CHI board intact going in to open a new hospital. I have to say there is absolutely zero confidence in the CHI board, zero confidence in the management, notwithstanding the changes you've outlined, Ms. Nugent, but there is zero confidence. And I'm speaking as a medical professional who would be inclined to try and tease out the nuances of this. There are no nuances. I'm going to yield to the our visitors.
Thank you, Deputy. And firstly, if I in any way did not convey the gravity of the situation, I apologise. It keeps me awake at night.
I accept that. Okay. I accept that.
So in relation to the governance structures, like any new CEO, I've come in and I have reviewed them. Notwithstanding the HICWA report recommendations, those structures were put in place at a time when the new Children's Hospital was imminent. However, we have corrected the issue, for example, of the site responsibility for the clinical directors. They no longer have that. I've changed that. We have enhanced the supports they have. In addition, we have clinical specialty leads. We have revised their job descriptions so that they take on more of a management as well as a leadership role. This was also identified. And again, I think that will be a great help to the clinical directors. In relation to the executive management team, since my appointment, I have appointed a permanent director of people and culture. Obviously, that's a huge focus for us. He took up his permanent role on the 7th of April. The director of operations started on the 9th of June, and the deputy CEO will be starting on the 7th of July. And I have two other posts on the executive management team that were temporary that I'm progressing to permanent. This is important to stabilise the executive management structures to ensure that we are fit for purpose. So a lot of work has been done in regard to that. I fully accept it is a systems process response. It's never one individual. In relation to the medical device management process, we now have a clinical ethics committee in place. That's important because, in paediatrics, unfortunately, manufacturers don't always manufacture paediatric-specific devices, etc. So we have a clinical ethics process in place by any off-label use of a particular device, in other words, using it for a different purpose for which it was originally designed. Any non-CE marked devices are also brought to that committee.
Could I interject, please?
Sorry.
And we can. No. I accept everything you're doing now. But I'm going to ask Ms. Hardiman. You were the CEO of the hospital at that time. A surgeon was suspended because of the spinal spring, non-medical grade spinal spring being used in surgery. What sanction did management get? What sanction did you get?
First of all...
And by the way, the hips happened on your watch as well.
We just have 30 seconds left, so sorry.
Right. Deputy Daly, first I want to echo Ms Nugent in relation to the heartfelt sympathy for what actually happened. This shouldn't have happened in CHI. And we have been on record with saying that we fully accept the HIC report. It did identify that there were weaknesses in relation to the management, and I welcome the changes that have been brought in. In relation to the surgeon, and appreciate that there is a process there, and to be clear and honest about it, he went on voluntary leave, which is a separate process than, just to be, for the record, to be clear, as opposed to suspension. And we went through that actually process then, and further HR processes.
We yield our time now because we've had our time. But we may come back to if we come around here again.
So our next slot is for Sinn Féin. Deputy Cullinan.
Chair, I've never found it so difficult to prepare for a session of any committee. I've been in the Oireachtas since 2011. And the reason why I found it so difficult is the full breadth of crises and scandals in CHI. It's almost impossible for us in this session to give any justice to the families who feel very let down, Ms Nugent. We had the Boston Review, we had the HIC review into the use of non-medical grade springs, we have the waiting list still for children with spina bifida and scoliosis, we had an audit into hip dysplasia, potentially hundreds of procedures that were carried out unnecessarily, and we have this unpublished report which cites concerns in relation to oncology, urology, orthopaedics, a lot of different issues. It's frightening what was happening in CHI, and families, I have to say, feel very let down. And it did happen on the watch of Ms Hardiman, the former CEO, who now has a very clear role as well in relation to transitioning to the new children's hospital, and that does worry people. It worries me, and I can tell you it worries parents as well of children, some of whom are in the public gallery, and by the way, can I welcome them as well. And I've never seen an opening statement that had the word apology and sorry in it so often, which is necessary, but it shows the gravity of the issues within CHI as well. But we have to put that sorry to the test, Ms Nugent. So I just want to start first of all with Ms Colleen White, if I can. So this unpublished report, and we had what I would describe as an editorial version or a sanitised version published by CHI, but it has been referred to on Garda Síochána. Isn't that right, some elements of it?
That is correct.
Who referred it to on Garda Síochána?
I did.
Why did CHI not refer to on Garda Síochána?
As you know, this report was done back in events of 2021. And my understanding is at the time, once the unsubstantiated allegations in the report were investigated, they did not meet the threshold for criminality.
Oh,
but I respect...
No, sorry, one second,
sorry.
Ms Nugent. It is CHI's view then that it did not meet the threshold. Ms White, since you did refer that to an Garda Síochána, did you get any correspondence or any view from CHI in relation to even now whether they felt it was appropriate for it to be referred to an Garda Síochána?
So any suggestion that public money is not used
No,
for
I
the
didn't
intent...
ask that. I asked that since you referred it to an Garda Síochána, have you had any communication or view from CHI as to whether or not even now it should have been referred to an Garda Síochána?
CHI have verbalised an opinion that it doesn't meet the threshold for referral.
Since you referred it on?
That is correct.
I just find that extraordinary. And the HSE was informed about this, we're told by CHI, this unpublished report in March 2022 at a meeting. That's what CHI say. Is that correct?
So CHI have indicated that, but I can confirm that the minutes of that meeting have been reviewed by the Health Service Executive, and there is no reference to the report or its recommendations.
No
or
reference
its findings
whatsoever. So when
at
CHI
that
say
meeting.
that they informed the HSE of that report, is that accurate?
The first that I, as REO and the CEO, was advised of the existence of this report was on May 24th, 2025.
Yeah, so, I mean, I can't accept that there is any cultural shift, I have to say, within CHI, a culture of secrecy. What was in this unpublished report talked about a culture of silo mentality and a toxic culture within the organisation. And I believe that despite your best efforts, Ms Nugent, you have a lot of work to do. And I want to get to some of the issues, in fact, in this unpublished report, because I know you and, again, the HSE, and I spoke to the head of the HSE on this, sought for a pseudo-anonymised version of it to be published. That didn't happen as well. So there's clear conflict, clear differences between the HSE and CHI and all these issues, which really troubles me. But just to come to some of the issues, because they're in the public domain, and I'll start with children that were called Crumlin orphans. Ms Nugent. And my understanding is there was a report carried out in 2017 by Mr Dixon that is now called the Dixon Report. Is that correct, first of all?
That is my understanding, but I don't think that report was accepted by CHI.
It wasn't accepted, certainly wasn't published, but the important part is whether children were notified, because that report, and I'll read from it, an extract which was in the public domain, published by a Sunday newspaper, says, evidence from the gathered patient information shows that patients in both Temple Street and Crumlin have been neglected and have not received the level of care which would be expected in the modern day in a country with developed healthcare. So what I'm asking you is that, how many children were identified as part of those orphan children, and were the families of those children notified, first of all, of that Dixon report and of any concerns that were raised?
There were 34 families. I'd have to defer to my colleague in relation to whether they, I suppose this
No,
dates.
as of now,
Yeah.
have families been notified of any concerns that were raised in relation to the care that was given to their children, what's described as suboptimal care?
But just so I'm clear, Deputy, are you talking about the Dixon report?
Yes, and the unpublished report, which also cites, so we have two reports now, which cites issues in relation to these orphan children. Because I know that the advocate groups and parents, some of whom are in the public gallery here, have sought that report, haven't got it. They feel stonewalled. They feel they're meeting with a wall of resistance. This is what they're talking about when they say they're being failed. It's their children. If it was my child, I would want answers. So I'm asking, were the families notified?
So when this report...
It's yes or no, were the families notified?
Not to my knowledge.
Not to your knowledge, exactly. And no, sorry, with respect, that is a failure, that families were not notified. Can I move on then to another section which is also troubling for me, because there's patient safety issues. A procedure called orchidopoxy. You know what that is?
Orchidopexy.
Orchidopexy,
It's a surgery
yeah.
for undescended testes.
Exactly. And in this unpublished report as well, because this was again in the public domain, but it was in part because of concerns about delayed waiting lists. And it said, this is one subset of these patients, and it says, despite an existing alternative option being available for quicker treatment, patients with undescended testes who require this procedure are waiting far in excess of the recommended time frame for treatment, placing those patients at real and known risk for fertility issues and or cancer in later life. I mean, that's shocking that that can happen. So what follow-up is done on that?
First of all, if I may, this report was initially commissioned in relation to interpersonal issues and team dynamics, and the 45 participants who entered into it did it on a confidential basis. And when I looked at this, doing a pseudonymized, anonymized or redacted version, they made no sense. They would make no sense to the public, because we do have a
Well, it does make sense to me, Ms Nugent, if I can just be very clear and blunt, because you're talking about, you know, information that has not yet been disclosed to the patients. When I see that there was patients with undescended testes who were waiting far in excess of the recommended time frame for treatment, and that it placed those patients at real and known risk for fertility issues or cancer, that jumps out at me. And I want to know, again, if any of those patients were identified and contacted about those concerns.
Right. So in relation to open disclosure, that was discussed at the time, and it was discussed with the clinical experts, and I would hand over to my colleague, Dr. Goldman, to explain the clinical
But I'm asking
element.
again, because I don't want, with the limited time we have, I'm asking a direct question. Were the parents of those children contacted in relation to those concerns?
They did not meet the threshold for open
Again,
disclosure.
they weren't contacted, right. I just find all of this incredible, right. It also raised concerns in relation to oncology. So is it also true to say that there was a risk assessment, a CHI oncology risk assessment that was completed on the 27th of August 2021 in relation to the oncology unit, isn't that correct? And it scored a risk of 20 out of 25, a high risk, which it says, because it was a high red risk, that they cannot be accepted and require significant management focus to mitigate them. In fact, it says, Ms Nugent, paediatric oncology patients have a poor experience or are harmed due to the inability of CHI to deliver international best practice standards. Again, it talks about prolonged recoveries. So again, I'm asking in relation to those cases, were the parents of those children notified of those concerns?
Not to the best of my knowledge.
So I just find all of this like absolutely profoundly shocking. And CHI can say what you want in relation to how this report came about. It is shocking to me that it hasn't been published. It's shocking to me that not only on this issue, because you can't look at this in isolation, Ms Nugent, you have to look at all of the children who had surgeries carried out unnecessarily, children waiting for care, some of them in the public gallery, their children are waiting for years, so-called orphan children, as they were described, that got suboptimal care, where parents have been asking for reports. They know they exist and are not being given them. Parents who are not informed of risks, issues identified in relation to oncology, in relation to urology, in relation to orthopaedics, differences between the HSE in relation to whether or not that report should have been referred to An Garda Síochána, differences in they are categorical that they did not receive the report even though CHI say that they did. So I don't accept that there is a cultural shift as far as I can see, given all of that. So what I'm saying to you, Ms Nugent, is to say that you have a lot of work to do is an understatement, and to say that I'm concerned that the person who was in the lead position when all of this was happening is also the person who now is a lead in transitioning to the Children's Hospital, I think is absolutely ridiculous and will anger the public and will certainly anger the parents of those children. One final question I have that I just want to ask.
You're running out of time then,
the
Deputy.
clinical director very quickly might answer this question. The multidisciplinary team reviews in relation to kids with osteotomies, there was, I think, 72 that were seen so far. How many need to be seen, and how long will that take?
And just very briefly, because we're over time.
Okay, we've seen 72 so far. We are expecting to see roughly 1,800.
How long will that take?
We are hopeful that we'll see the majority of them within 6 months.
Thanks very much. Our next slot is a slot for Fine Gael. So, Deputy Roach.
Thank you, Chair. And firstly, it's a welcome development that you're here, and I want to thank you for your comprehensive summary. It's quite difficult at times to, when you hear the stories and the impact that has had on children, and as part of the report that you brought before us today, I have to say it's reassuring that the necessary steps, the very important steps that need to be put in place are being considered, and obviously the move to the new hospital, that is the perfect opportunity to ensure that all compliance is there. But the real question, I suppose, and the real reason that you're here is that fundamental mistakes were made, and obviously fundamental that has had a fundamental impact on children, and not just the children that had surgery, botched surgery, but also in most cases young parents that are left, I suppose, with picking up the pieces. We all know, and we've met, indeed I'm one of those that had a visiting child that had been impacted as a consequence of one of those procedures. And when I look back on it, it galls me to think that because you wait in anticipation for a full recovery and for the next procedure, whenever that would be, to get this child into, if you like, full mobility in the future. And for me to learn that that child was informed very recently that as a consequence of the previous surgeries, that right now they are not going to be considered because of the enormity, I suppose, or the impact that would have on the child due to the legacy issues, if you like. And, them are the real issues that have yourselves here today, and I thank you for coming in. But it's a calamity that you would have to be here, because one would expect when you bring your loved one, your child or otherwise, to any of the hospitals for procedural operations, that would be done so with the very, very highest of integrity and highest standards, and obviously where any ambiguity or indecision is certainly not a consideration. And we've had this discussion and debate over the last couple of weeks, and God knows it's I don't come with a medical background, but I certainly come with a high degree of empathy, and it kills me when I hear of the pain and suffering endured by some of those patients, some of those children. And I notice, you know, you said, and you still maintain that, you know, that there's no good reason to publish the full report. And I suppose that's my first question. Why won't you publish the full report, or even a redacted version of that? And you touched on the reasons, or some of the reasons why you felt it might not be appropriate or otherwise, but if there's nothing unsurmountable in that report, or if there's nothing really toxic about it, I can't see any reason why that would be withheld. That's my first question. And my second question is there an independent review of how internal conflict and cultural issues at CHI affect clinical safety and patient outcomes? My next question is, what specific targets have been set for clinical and cultural integration ahead of the move to the new hospital? And how will CHI ensure that the new hospital is not just a change of location, but a transformative and caring institution? And what safeguards are now in place to prevent the introduction of authorised or untested medical devices in CHI hospitals? And I have two questions to put. Obviously, you know, that I think are quite significant, and I want to put them to your good self, and that is, if you don't mind, can you or will you confirm that meetings did take place with two surgeons at CHI Tempest Street and at Captain National Orthopaedic Hospital on the 20th of February 2020? And can you or will you confirm that these surgeons sought your guidance on the introduction of what I would describe as novel medical devices? Margaret.
I wasn't in position in 2020, so I'm unable to answer that question. In relation to introduction of new medical devices, as I said previously to Deputy Daly, there is a process now in place with the clinical ethics and also with a medical device management committee, which I chair. So I am certainly more confident that certainly only approved devices can come into CHI. And that includes things that, you know, again, was in the public domain about the use of gastrostomy buttons. They have been in use for 15 to 20 years. There's a lot of scientific research about it. But they had to be grandfather claused through the Medical Device Management Committee, which has been done. And again, you know, I know from talking to a parent recently, they're very happy that they have that device. But there needs to be a process. Innovation is important for medicine and for healthcare, but it has to be done in a way that protects the child, protects the individual, you know, with a good idea, and the organisation. In relation to culture, we know we have to do a huge amount of work on this. It's not right, it's broken. We're bringing three different cultures, we're merging them together. But the values are the same. They are very much focused on children and on delivery of the best care we can do. So there's a lot of work ongoing in relation to that. There's a culture programme that has started, a change programme. We have immersion projects with staff. We have staff rotating to work with each other. So they actually, the person I'm working with today may not be the person I work with tomorrow. So again, we need to make sure that we are ready for the new building. It's just a building. It's a fantastic building, but it's just a building. It won't deliver care. The people will. So we understand that. There's a meeting on the 3rd of July with the HSE. I've met with the National Director of Culture, and we are happy to engage in a newly launched cultural programme. If we can get it right in CHI, it'll get it right anywhere. But that's really important. And I think the most important thing about this is, are the staff willing to engage in this? And they are. As I said previously, the Irish Times letter that my almost 200 consultant colleagues wrote stated that. And we know that we have to do better. Because if the culture is right, then anything else, I think, is possible. In relation to, sorry, I forgot my note here. In relation to conflict, yeah, I mean, this report was originally commissioned because concerns were raised an intervention happened with that team, so action was taken. There were 34 actions. There was monthly minuted meetings regarding that to track the change and action was happening. In relation to the publication, unfortunately, I have taken legal advice on it, and those people participated in that. They trusted that it was a confidential process. I need to maintain that trust amongst my colleagues because we have a lot of work to do. They have not seen that report. It wasn't shared with them. Some of the statements in the report were not substantiated in the long run. And again, I suppose that's the piece of information that's missing. So from that point of view, fair procedures would have to be given to the individuals involved, etc. And we hoped, and I understand from your feedback, that somebody didn't provide that assurance.
If I may, just in the brief time that my questions which were asked in the meeting in 2020 were directed to Ms. Hartman. That's all right.
Yeah, thank you, Deputy Roach. I'm happy to discuss this. And to clarify, there was a meeting in 2020, of February, in Crumlin Hospital with one clinician, the management, the Kappa Hospital, apologies for that, and the management of Kappa, management of Temple Street, and myself. That meeting was in the diary in response to an invite from the clinician to discuss Kappa and how we can use Kappa more to actually help address the waiting lists and issues. That meeting is in my diary, it's documented, I have notes of the meeting, and subsequently the clinician and I had exchanged emails about what was discussed. Devices were of the nature of relation to the springs were not discussed at that meeting, and should not, because that's not something that Kappa actually does. We did discuss, though, magic rods, and the reason why we discussed it was the field safety notes that had come out earlier, and we raised it as an issue, and I responded to them in emails specifically relating to that, which is a separate device matter. Where there's a difference is that two clinicians are claiming that they popped in to meet with me in Temple Street earlier that day. I have nothing in my diary. I have my office has no record on it. I have nothing in my notes about the meeting, and I have no memory of it, and I do not believe I'm stating that that meeting actually occurred. So,
We're just over time now.
So just to be clear, reference to, and I hope I've done it clear about that.
Thanks, Vin. We're actually over time on that session. Thanks so much. The next slide is for Social Democrats, so it's my time. Like others, I kind of struggled to know where to start, to be honest. We could be here for a number of days. We could be here for weeks with a list of questions that could be asked on all of this. My conclusion is there's a toxic work culture in parts of CHI. There's dysfunctional internal communication and poor governance. And I'm not really satisfied with the answers that we've been receiving in relation to the publication of reports. So I would ask, would it be possible to share the legal advice you've received in relation to that report? You're happy to share that with the committee? Great. And what I would say more generally on this, there are ways of disclosing these. You can redact the names. You can engage with the people, and if things are contested, that can be noted in the report. But what I'm hearing is that there's kind of this constant reluctance to disclose information and to share information. And I think what we need is accountability and transparency and full disclosure from CHI. And I think that's how you begin to repair the trust, because trust is broken. And I think that would be a very good starting point. And linking to an earlier discussion, I know there are many patient advocates who've asked about previous reports and they've been denied those. Can you explain why those reports, like the Dixon report, wasn't provided to those who were looking for it?
My understanding is the Dixon report was never accepted by CHI as a report.
I might be able to help about it. The CHI, it was actually a report that was commissioned by Temple Street through CHI. It was not accepted by the management of Temple Street at the time and the colleagues in Crumlin, so it was not there. And yes, it did identify matters that were actually brought to the attention of matter and addressed through the report itself, and the findings and methodology was not accepted because there was concerns about it.
And does the agency share that view in terms of that report?
So that report is before my time in terms of the Dixon report, so I can't comment on CHI's view on that.
Mr. Henry, comment?
Not aware of that report. I haven't seen it, Deputy.
I'd like to move to the unnecessary hip surgeries. Really shocking, distressing, disturbing, and I acknowledge, Mr. Nugent, you said you're equally distressed by a lot of this. But I think there still are questions remaining around all of this. So the audit period is a 2-year period. Letters went back to 2010, but how far back does this issue go?
The audit period itself is 2021 to 2023. Decision was made, though, to look back further to 2020 to 2010, as that appeared where that appeared to be a time point where practice varied and also allowed us as CHI to follow children up to skeletal maturity. Unless my colleague Ike wants to add anything else.
No, I think you have it covered. So the 2010 was chosen by us because...
So you just have to turn on and off your mics.
Sorry,
There's a button in front of you.
Sorry, Deputy. So we chose 2010 for 2 reasons. One, we wanted to make sure we captured all the children who had osteotomy and who were still under our care. So if we had brought it too soon, we would have missed some children out, and we didn't want to do that. And then the second reason was that there was a publication by one of the senior surgeons in 2010, which described the approach that they use.
But that paper is based on surgeries that happened before 2010, is that correct?
Yes, but if you look at the paper, the acetabular indices used there were fairly generous, and they weren't using that low threshold approach at that stage. So we felt that the change in practice would have occurred from around 2010. I mean, if we look back to 2010, there is still scope to look back further, but we want to identify where that practice started first.
And I suppose the big question that remains for many of us is, why did this happen? Like, we know what happened, but nobody's been able to tell us why.
You want to take that? That's a good question. So that's the reason we did the audit, was to first of all to establish, whether there was a difference in threshold. And the auditor found that, as you know, you've seen the report, and we found that the surgeons in Cromlin were compliant largely with, with what international practice
I've read the reports,
was. We found that within a group of surgeons in Temple Street and Kappa, there was a philosophy that they had that if you intervened earlier, that you do prevent children when they're older, when they're young adults, from having osteoarthritis and needing hip replacements. It was a philosophy that they firmly believed.
How many of the children who had unnecessary hip surgeries had private health insurance?
I did a snapshot. I know in the public media there was a suggestion that this was done for financial gain. So in the audit period, the number of private patients in the 2 CHI facilities were 25% and 26%. This is well within the contractual norms of under 30%.
Is CHI ruling out financial incentive as a motive and putting it purely to philosophy?
Yes.
In relation to the procedure, it was identified that it was a novel procedure. Were families informed that this procedure was novel? The report that I read says it's a novel procedure, lower threshold. Like, were people informed of that?
So my understanding, again, I will defer to my colleague in a minute, that procedures are modified all the time. You might start, a consultant might start doing something as they were taught as a trainee, and then it might be slightly modified based on the need of the patient or skill sets. But I would defer to my clinical colleagues, maybe even Mr. Moore, in that relation.
Was there informed consent?
Oh, no, sorry, I'm talking about procedures.
That was the question.
Informed consent. Informed consent.
Were they informed that it was not a
Yeah.
procedure? That's the question I'm asking.
Informed consent is taken at all interactions regarding doing a procedure. So from that perspective, informed consent has to outline the reason for surgery, the risks, the benefits, the risk of not doing anything as well. So that is a standard process across CHI, and we are enhancing it. We have a new consent form that has been launched at the moment, which goes into even more detail as part of our learning
So
from
is
the
the
HIP
suggestion
work.
patients were informed that it was novel?
Well, I cannot confirm or otherwise, because I wasn't,
Mr. Moore?
who wouldn't have been there either.
I can't speak as to what the patients were informed, but I would agree with what Ms. Nugent said. Any procedure that starts off and was designed 40, 50 years ago with particular equipment available or understandings of how things are done will regularly be, it will evolve over time and people will modify it. I'm not quite sure what the procedure was here, but it is normal for procedures to evolve over time.
Great. In terms of HSE, do you have anything to respond on any of that?
Yes, in specific, Deputy, in relation to informed consent, is it?
Sorry, you were indicating.
Yes, so having spoken to Mr. Thomas a number of occasions, he described this surgery. It's essentially a preventative type of surgery, as I'm sure you're aware, where clinicians' purpose is to prevent hip dysplasia developing in adolescence or later in life. And his findings in the audit were that not just that there was a lowered threshold for surgery, which is he's characterised at an extreme end of variation, but that the kind of discussions that you would expect to take place in those audited samples between a surgeon and a family to explain the pros and cons of the relative risks, he couldn't find evidence that had taken place in the audited samples. So that isn't to say that didn't take place, but he didn't find evidence that that kind of would be quite a complicated discussion, but a necessary discussion to have with families, explaining why you're intervening at a certain stage to prevent something that may happen later. And even in the best practice centres that comply completely with the standards he laid down, you won't expect them to get the decision right 100% of the time, because they're trying to prevent something happening later. So his characterisation of that was he didn't see evidence in the audited sample that those kinds of discussions took place.
Just in terms of, in the final minute, in terms of caseload management, are there defined maximum caseload caps on orthopaedic surgeons or consultants in CHI? Is there caps on the number?
I'm sorry, I'm not quite sure I understand the question.
Are there defined maximum caseload caps for orthopaedic consultants in CHI? I suppose my question is around like the growing list, the number of patients. Like, is it clinically safe to continue to assign new patients to consultants who have got significant backlogs?
Okay. So one of the learnings from the unpublished report was that we need to ensure that there's equity of access. So if one consultant has a lower waiting list than another, then obviously you would rebalance those lists so that all patients have the same wait times, albeit they are too long. So the Central Referrals Office has been created in CHI, whereby a referral comes in to that and is assigned to the consultant with the relevant expertise and the lowest waiting time to provide that equity.
That's time on that slot. Our next slot is Fianna Fáil. Senator Costello.
Thank you. Ms Nugent, I'm sitting back here and I'm looking at you answering all the questions, and you are new. So, Ms Hardiman, the questions that I have are for you. First of all, what accountability for management's failure of governance and around procurement? Like, where's the accountability? Do you think that you maybe need to rethink your position on this? This all happened under your watch. There's a saying, do anything on me, it's okay, do it on my children and we have a problem. And like, you know, parents are very annoyed when their children are let down, and by God, these children were let down. First of all, I've a few questions, so I'm going to fly through them because I do want answers. Why did the clinical indication rates vary so drastically between Crumlin, Temple Street and Kappa? What oversight existed over the individual consultants' surgical decisions? Were any concerns raised by colleagues or management at the time? We already spoke about, were parents fully informed? Was there informed consent? To the use of non-CE certified springs in children's surgeries, like, what checks failed in the hospital's procurement or clinical governance process for that to happen? Like, I come from a procurement background. I would assume that there was a process in place for ordering these products. So how? Like, I can't get that. out of my head. Was there any testing or risk assessment done on the devices before implantation? Sorry. What role will external bodies like HSé and the Medical Council play in investigating and enforcing accountability? Because accountability is something that I'm going to come back to, and, you know, management need to be accountable. I don't believe one person is to blame here, and I certainly don't like the idea, and maybe, like, I'm not a medical person, I don't like one person being a scapegoat on a situation. So I think, you know, the rot usually happens from the top down. So why was the internal report not shared? Like, I was reading notes, and it was saying a report wasn't intended to be made public or to be published to ensure that the staff felt safe to participate. That's like, secrets are, you know, they breed trouble, you know, they breed exactly what was going on, like a poor governance, toxic workplace. You know, how could things go right? Like, children have been so let down on their families, and yeah, I'd like answers to the questions I asked.
Thank you, Senator Costello, and I'll endeavour to do that. First, I will reiterate the apologies for all of hurt or harm that's been caused and distress to families. I was before the previous Health Committee on this matter, and I reiterate that position. Working through your questions, to take the issue of procurement, if I may, it has been identified that through the HSé report that these springs did not come in through the procurement process. There is a process around procurement, and it was outside of that. Since then, we have improved the procurement process, whereby this could not happen again, and those controls have been put in both in the procurement side of things, but also in relation to our processes within our theatres, and more importantly, I think the medical devices committees and structures that have been put in place within CHI, because we fully accepted the reports from HSé. So I believe that we are at a strong standard, and I think the assurance can be given, I would say, through Ms Nugent, that those processes are in place.
Is there a new procure-to-pay system or something that's been put in place, that there's no room for error, that non-surgical items can be purchased?
So historically, there were multiple points of entry into the goods come in to Temple Street. We now have one centralised procurement function, so you cannot get anything into the hospital. Since 2023.
2023. Yeah.
Why was that the case? Why was it coming from all angles as such? Why was there nothing proper, like, given the importance of our children and their health?
Yes, Senator Costello, it was always the intention to move to the one system of procurement. It had been implemented in Crumlin and Tala and in Connolly, and the next implementation was Temple Street. So it was always in our plan for the one standard of procurement, which is a very robust process. So it was part of our rollout of the implementation to single process.
What was the delay? Why did it take so long?
It was just a phased approach, because we could only do it one place at the time. So it was as part of a process. Our integration was rolling out single corporate systems around, and it was just on a programme of work.
And as we're just tight for time, what accountability? My first question.
Yeah, I think
with regards to your position.
I think about the process that has been brought in, particularly the medical devices and I would say the ethics committee, and both are actually robust processes where any new innovations, if a clinician, I think, wants to discuss, modifications, they actually have a process that they can actually bring these up through within CHI, and that then gives the assurances, I would say, to the families and parents and to who we serve, that they have been tested through that particular process before they're actually implemented.
And do you feel that you've been held to account?
I've been open and honest in front of this committee and apologise for the failures that we've accepted the report in relation to HSé, but I think we also have a particular specialty that is a particular focus on this, but we have 38 other specialties that are, working a lot of them some to international practice and even meeting international benchmarks in relation to their clinical outcomes. So there is definitely, I believe, that within Children's Health Ireland, some of the issues were Children's Health Ireland, their legacy issues. Some of the issues definitely are with the massive change that we were trying to implement, and we actually accept those. And I think we were in a process of actually trying to approve them. Many of the issues that were actually raised by our staff and within CHI, except for the Springs. Everything else came through it. So our staff, I think, are very, majority of them very committed, child-centred. You know, they care about what they're doing every day. And we did not have, I would say, a culture. And we, particularly in 2023, went out to the staff through Open Hall and said, please raise your issues, bring them to us, we will address them. And I think the internal report, while it has not been published, but I think the assurance, and like Ms Nugent look at it, not me saying this, was that those issues that were brought up were addressed. They were put through processes that previously hadn't been addressed. And the staff and that particular service are in a much better place now. And just to give assurances to families, that's a much safer present, and not just because of that internal report, but because of the management systems that was in at the time, particularly around the risk assessment, which didn't wait for the report to come out. It had come up through us and it had been addressed, and it was actually been addressed with the support of the HSE. So we are unusual in that we are merging, and there are different cultures and there are differences, you know, and those are the things that we need to work with staff, and they need to work with us in a trusting way.
Place where, like, it shouldn't be a toxic environment. It's a place where children's lives have been affected, and I'm still not really hearing an answer on accountability.
Yeah.
Like,
well, I absolutely agree with you, and the vast majority of our staff would say that it's a good place to work, and they actually have a good working environment. And yes, the matters that were raised were shocking. A lot of them, and I would say particularly in the internal report, were pre-CHI, and there were legacy long-term issues that we actually got out in the, when I say open, we worked with the people involved, the staff involved. We put in the process to actually address them. We implemented the HR policies that hadn't maybe been implemented up to that time, and we have now a better service. We have a happier team, we have a more cohesive team, and we have a safer service, I would say, from that process.
okay. I just, like, I know you at times have said you've no recollection of being told about issues around things. Like, that's different to being actually told, like, you know, not having a recollection, sorry. That kind of concerns me. I still don't feel like as though, you know, for parents, if it was my child, I would feel like listening that people have a happier workplace and stuff. Like,
are you, Senator, are you relating to
I'm
the
saying
meeting? Is it the meeting?
Springs.
Yeah, no, I've been absolutely clear. HICWA in its report said that there was, and it confirmed this, that no one from senior management approved those springs, or were aware of it, but that's in the HIC report. So I did not have a meeting in relation. That's my position. It's not a. I have no evidence of it. I have nothing from my diary. I have my PA has nothing in her diary. I have nothing in my log.
So finally, how will CHI's governance be restructured to prevent the reoccurrence?
So we're over time on that one, and we're due to take a break. So what we're going to do, I have 6 members remaining, so we'll have 10 minutes each per member to come back with. So we want to be strict on terms of the break. So taking a 5-minute break, and then we'll come back, and then we'll have 6 members remaining who have 10 minutes each, and we'll finish at 12. The committee will now further consider the treatment of children with hip dysplasia and scoliosis and related matters. Next on the list we have Sinn Féin slot, Deputy Clerk.
Thank you, Chair. And you are welcome here today. I'm really, really disappointed that we have to have this meeting. But I suspect it's going to be the first of a series of meetings that we're going to have on issues like that. And I find that absolutely deplorable. People trusted their children into the care of CHI. They're children. Children aren't small adults. They have a very specific set of needs. And in my opinion, and I say this as a TD and as a parent, I think you abuse that. And I think the parents, not only are they stressed and anxious, as you referenced, Ms Nugent, in your opening statement, they are absolutely furious. And that wasn't referenced or acknowledged anywhere in your opening statement. So I wish you luck Rebuild and trust. I have children, they have been to your hospitals, they no longer need to, but I'm not sure that trust would ever be rebuilt with me if I was in the situation that these parents are in today. So I have two areas that I want to ask questions on. One is around clinical review meetings, and the second is around the retrospective review. And we are tight on time, so I will just get straight into it. In terms of specifically the hip dysplasia advocacy group, what they are saying very clearly is that many of the families where children were included from the audit from 21 to 23 and have gone back for their review meetings, they have been informed of further investigation has been mentioned to them. They were under the impression that the clinical review would be the last step, would be the closure step. So can you provide clarity on what the additional steps are planned and how those steps differ from the initial process? Secondly, who will be on the panel conducting the independent international review? And what is the purpose, again, of a second stage? And how does that benefit the children and their families? And as part of that, is there different thresholds being used there as opposed to the initial stage of the audit? Very concerningly for me, I'm told that the clinical lead was unable to answer a question as to whether children, regardless of their surgical justification, face long-term risks due to the modified surgeries that they underwent. The families are asking very reasonably for clear, evidence-based answers. I'm also told, again, very concerningly, that some physiotherapy sessions were conducted away from families, without explanation and without consent. That is really serious. That needs to be answered. Those parents need answers as to why that happened. And the last question to this part is this. If it should become a case where families need to travel outside of the state, what does that look like? How would a process like that work? And as a comment, I put it to all of you, that it is not acceptable for a family to travel from the west of Ireland for a 5.5-hour appointment and nobody even offered them a cup of tea. You talk about trust, you talk about compassion, you talk about all the good that CHI does. That's human, that's basic stuff. 5.5-hour appointment, having travelled from the west of Ireland. Now, going to the retrospective review, and again, I'm going to get straight into the questions. These parents and other parents who have children in a similar situation, will they be engaged with in terms of drafting the terms of reference? Will you take on board their concerns, what their lived experience of this outcome has been? When findings are being communicated, they are asking that it's done with full and open disclosure. Now, you had referenced earlier on that there had been informed consent from parents in terms of the novel procedures that were carried out. I put it to you, Ms. Nugent, that the parents, some of them anyway, say very differently, that they did not give informed consent. Another very reasonable ask, to my mind, is that when the review results are published and when they are put out there, that none of them are labelled as inconclusive. These parents want answers. They want full answers. They want complete answers. And finally, the panel that will be composed, are they all independent international paediatric consultants with no affiliation to CHI? Who are they? Where are they from? And what's their expertise?
Thank you very much, Deputy, and I apologise if I misled you in relation to informed consent. I outlined the process. Obviously, I can't confirm otherwise or not for each individual child, so I'd like to clarify that. In relation to the current review clinics and the physio assessment, I might ask my colleague Dr. Okafor to answer that in a moment, because he's been attending those clinics. In relation to the expert panel review, that has been conducted by the HSE, and I would defer to my colleague Dr. Colm Henry for that. But in relation to the physio assessment,
thank you. Thank you, Deputy. Sorry, I keep forgetting.
it's okay. No, turn it off. Yeah.
All right, it's on now. So, yeah, we had our first set of multidisciplinary assessments. These clinical assessments were purely clinical, and they were supposed to assess the current state of the children, so to see whether they had any complications, to see whether they had any ongoing symptoms. So we had senior physiotherapists who were there and who assessed the children using a HIP score. So the HIP score had different components. One was a questionnaire where there's a self-reported outcome, and then there's the other assessment where they assess range and they assess gait, and then there's a final score that is done. Children who needed to have x-rays went for x-rays, and then the final piece was that they spoke to the consultant orthopedic surgeon, all of whom were independent and were not the primary surgeons who saw the child. That piece went, I mean, it was the first time we were doing it. It was Friday, Saturday. We hadn't anticipated really how long it was going to take. We had actually planned to see 70 children over the 2 days, but we had some people who cancelled and we had some did not wait. I think the Saturday we got slicker. We identified areas on Friday where things didn't go right in terms of the flow, and we definitely had people home earlier on the Saturday. But it was generally, we were able to capture everything we wanted to capture in terms of the outcomes. And you're right, in terms of the data, I think when we see the vast majority of children, we'll have an idea then what are the complications, and only then can we quantify what the risk will be to children where they are getting this surgery using this, this type of philosophy of a lower threshold. But we started with children who were in the audit, so there were children who had surgeries between 2021 and 2023. So they're still relatively young. I think where we are going to start to see some of the data in terms of long-term possible complications are when we start to see the older children. But I think it would be good to actually put it together and publish something and say, listen, from the number we see, these are the numbers with, with these and that. And that would give parents who have younger children some kind of an idea what to anticipate or what to expect. In terms of the external follow-up, I'll defer to Colin Henry.
Thank you, Deputy, for the question. So just to go back, as succinct as I can, and review the report, and having spoken to Mr. Thomas, the author, it was clear that the most important thing for parents would be the clinical follow-up to ensure skeletal maturity and to assess the impact of the lower threshold of surgery. But it will also be really important to them to find out whether surgery was appropriate in the first place. Now that the finding was that there was a much lower threshold for surgery in 2 institutions. And this is exactly what I advised the CEO at the time. We went beyond Mr. Thomas's own recommendations, but we are applying that back to 2010. This is, in 2 ways, a difficult and complex exercise, Deputy. The first is we have some experience of conducting independent exercises outside involving international experts, and the very action of exporting data and information and radiology findings is in itself something that needs to be very tightly managed and controlled to ensure that the international experts you have all the information they need. And then the synthesizing of all that evidence into reports that then can be conveyed to families in a compassionate and supportive way is in itself an exercise that we have some experience of over the past few years. And so what we're doing at the moment, Deputy, is we have identified a number of international experts. I won't name them at this stage, if that's okay. And we're also getting the legal opinions we need to get necessary to set this up, to make sure that we have robust terms of reference.
You engage with the parents around the terms of reference?
Yes.
You'll give them that commitment?
I'm happy to engage with the parents as part of this process, absolutely. And then setting this up, convening this panel, having the chair named and secured, having all the legal supports necessary, will take us until September. And we expect then that the assessment of each case will take right through to the end of the year and into next year because of the number concerned. And I would stress, Deputy, it's really important, and I reference other similar exercises we've carried out over the years, is that part of generating the report and translating it to families and in a compassionate and supportive way is really important.
Can I, very finally, and I've 10 seconds left, will the HSE commit to make counselling and mental health supports available to both the children and their parents?
We'll support parents in any way they need when we're
and their children.
And their children when we're communicating these reports.
Thanks very much. The next slide is Fine Gael.
Thank you very much for your presentation and for the work that you are doing. And I know it's a very challenging time because you've also the whole amalgamation that's going to go on with the new Children's Hospital. Can I just ask, in the current waiting list issue, you've down that 65 cases are suspended. Do we have any idea as regards where those are now as regards, have they gone to other hospitals, have they gone to other jurisdictions? If they've gone to other jurisdictions and they come back to Ireland then, is there a support mechanism for them in place?
Just to clarify, you're talking about spinal patients?
Yes.
I will defer to my colleague, Mr. Morris, as head of the spinal unit.
So patients can be suspended for many different reasons. They can be clinical, or they can be at the family's request, or such as exams. Quite a lot of patients with non-complex surgery opt to have their operations, if possible, during the school holidays, so as it doesn't interfere with their schooling.
But of the 65 where the treatment is suspended, where are we with that 65 now? Are they just left sitting there waiting for further decisions to be taken? Or are they being provided with the, the level of care they require, and is it being provided in a timely manner?
So you mentioned outsourcing. If a child is being outsourced outside the public system, whether it's to the Blackrock Clinic or abroad, then they would be suspended on our waiting list until they actually have their procedure.
But is there a monitoring as regards making sure, and the question then is, there is going to be support for them once the procedure is provided?
Yes, on both counts. Every child, we have a dashboard that has every single child who's on the waiting list for surgery, and that is available to the clinical nurse specialists.
Right. Okay, can I come back then to the issue in relation to where a child was, surgery was carried out on a child, and obviously there's a team, there's senior registrars, there's registrars, and there's a consultant, and that process, the procedure that was carried out was deemed not the best way of managing that patient. And you now have, say, a senior registrar who's now become a consultant. Is it being clearly identified that where family do not want any part of that team to be involved in the care of that child, is that being looked at to making sure that there isn't that problem arising?
I'm not. I'd like you to clarify what the
well,
issue. I'm not sure.
Say for argument's sake, you have a senior registrar who was on the team where when the surgery was carried out. Family are aware of who was on the team. They're now concerned that they're referred back to that person, and that person is a consultant now.
I can't comment on that. I'm not sure of
But
an instance
are
where
there
that
processes in place to make sure that where concerns are raised by families in relation to the care they provided previously, that they're not ending up back with any part of that previous team?
Yes, certainly from on our service we would always discuss what's going on with the family and try to assuage their fears.
Can I move on to something totally different, and that's in relation to the findings, high attrition rate among support staff due to bullying issues, and then the whole issue about people in training really find it difficult. And I suppose anyone who's in training, whether you're as an SHO, senior house officer, whether you're a registrar, whether you're a senior registrar, because you're dependent on the person who you're under for reference into the future, afraid of raising concerns about the way they were treated. What's the process now being set up to deal with that kind of an issue? Where you have a registrar or a senior registrar who's not happy about the way issues are being managed, but are afraid of raising it because they're afraid of their future career prospects.
So we have regular inspections by the training bodies to ensure that we are meeting the needs of our trainees. In relation to, I think you're referring back to the unpublished report in relation to a trainee. In that situation, they were supported. We engaged directly with the training body. The training was paused until the cultural...
But you do accept that there is that issue, that where you have trainee doctors, that there is that issue, the fear of raising a concern because it may affect their future promotion prospects, or even jobs within the particular hospital.
You know, healthcare is very small. There's always a concern. I suppose in relation, and another reason why we didn't want to publish the report is we didn't want to identify the trainee in that respect. But in relation to, there are supports in place. We have had our inspections, the 2 inspections following that report. The last one was extremely positive because of the learnings and the steps that we put in place. We do have supports for our trainees as well. We have a whole training support system in place. And we, again, as we were saying, we want people to speak up for, you know, we want them to have the psychological safety to speak up if they are experiencing something or if they see something.
Do you
that isn't
accept
right.
that there was evidence that there were people who were concerned about processes being
Yeah.
taking place?
At that point in time, 4 years ago, yes.
And like that they were actually afraid of saying anything. And these were kind of consultants who may not have been in place for too long, but the senior people were there, you know, I suppose totally in charge. How do you now deal with that process into the future?
I'll defer to Dr. Goldman.
Thank you for the question. It's not acceptable, completely unacceptable for a trainee to be bullied, as was the case in that report. And certainly that would be totally unacceptable now. So you're right, how do you deal with that? And if the trainee is perceived to be in a vulnerable position? I certainly, at the induction of all the trainees when they start, speak about culture, about respect, about treating everybody and them being treated with respect, and that if that's not the case, for them to please speak up either along their line or to myself, if that's the case. And then, sorry, as Ms. Nugent said...
But then coming back then to, you know, the issue in relation to trainees, but then coming back to the patient, have we now a process in place that where a patient is unhappy or has questions and they're afraid of asking those questions, are we satisfied we're giving enough information to patients so that if they do have concerns, they can raise those concerns with someone who's independent of the care team that's appointed to look after the child?
We have a separate team, a family support and parent team, which is completely separate from the clinical team.
Are parents aware of that structure, and are they satisfied that their own position is not undermined by raising a concern?
I would hope so, and I would hope that we would stress absolutely that their position would not be. And we get a lot of compliments, we get a lot of complaints. And where there is a complaint, we take that very seriously, and we would look into that and assure the family that we are doing that and that they should not be compromised by that.
And in relation to the time procedure for when complaints are raised, this is the big concern that has been raised by me, by constituents, right over a long number of years. When they make a complaint in a hospital, the time scale it takes for it to be dealt with. In some cases, people not getting answers for over 12 months, 18 months. Are we now satisfied that we have a structure that can deal with a complaint in a timely manner?
Yes, there is a structure, and it's one of the KPIs that we monitor is how quickly are we closing out on any complaints, because I agree, if you need information, we should be able to provide it as timely as possible. We are hitting the 30 days. I forget the exact percentage. It has increased and is increasing, and that's an area of focus for us.
And just in relation to the whole process in relation to amalgamation now, in relation to, you know, you've different, and this is quite clearly from what occurred in relation to the surgeries where you had one hospital doing it correctly and properly, and then 2 others where it was totally, it now appears inappropriate treatment. Are we now satisfied that we can get all of the teams, when they come together in one hospital, to be working together, that there isn't a domination by one group over another, and as a result procedures are changed which mightn't be the appropriate way of dealing or managing a patient?
Just get a brief answer because we're running out of time on the slot.
What answer?
Brief answer, yeah.
Oh, yes. So in relation to the MDT function, that is something that we are enhancing, not just in HIPS, but right across the organisation, was highlighted in the HIC report. And in relation to culture, we are doing a piece of work targeted at that particular service that you are describing, and they have agreed to engage and are engaging in that process, so that we will have a new culture going into the new hospital. We're leaving the old behind.
Next to Labour Party, Deputy Sherlock.
Thanks, Chair. I suppose I just want to say, as the TD in Dublin Central, as a mother of three, I've had quite a bit of contact with Temple Street and indeed with the satellite unit in Connolly over the last number of years, and there is incredible work being done on the ground by staff who go above and beyond on a regular basis, and that's important to acknowledge, because I suppose when you look at what's happening on the ground and then the abject failure of leadership that has taken place within CHI over the last number of years, which I think has led to a serious issue with regards to morale now amongst staff. And then, of course, I suppose we've had this horrible set of revelation after revelation that is corrosive to both the confidence of staff in terms of their own organisation, but even more importantly in terms of families and patients attending. So, and I suppose, like others have said, you know, my head almost boggles in terms of the amount of questions that we have here today, and that we know we won't be able to have time to get full answers to. But I suppose my first question is to Ms Nugent, and then separately to Ms Hardiman. Are there other reports, both live or historical, within CHI that are currently with the board or have been with the board, given the seriousness of the situation, the incident, the allegation, whatever it may be? Are there other reports that are not in the public domain? Are there reports that have not been reported to the Minister for Health or indeed to the HSE? Because I, for one, do not want to see a drip feed of revelation and crisis and shock in the months to come. So I would like you to disclose today if there are other issues of seriousness that we should be aware about.
Deputy Sherlock, I asked exactly the same question because I didn't know about the unpublished report from 2022. So I have asked that of my executive management team. And the NIAGM report obviously still has to be published in that regard. And obviously then there are internal HR processes and training, but also the results of that will be known in due course. And as I say, it's to the best of my understanding.
So there are no other major reports or investigations or internal reviews?
Not to my knowledge.
Okay. Ms Hardiman.
I have actually discussed this with Ms Nugent. There is individual reviews of individuals, which would be normal part of a, part of professional development or a dealing with areas of competency that needed to actually be developed, through a normal development programme. And so there's some HR processes that are around to individuals that are going through the organisation. That's normal in that we would not be disclosing those because obviously they're due to individuals. I am aware that there's been reports that in relation to the we did ones about staff feedback way back actually in 2020, so that goes way back to then. Those have been shared with the staff, the results have been shared with the staff, and some of the professionalism results have actually been, we're actually moving on them.
Sure.
And they're staff surveys, if I want to say this.
But Ms Hardiman, just to ask, I suppose, that 2022 report very clearly set out that there was the behaviours and dynamics within a particular department had the potential to put patients at patient safety at risk. That was not reported to the Minister for Health. It was not reported to the Patient Safety Office in the HSE. Why did you not report that?
So to be clear, the issue that was raised in that was one of the issues was around risk, quite rightly. A risk assessment separate to the report, because while the report was collated in 2021 and published in 2022, The reality is our risk management processes had already kicked in 2021. So a risk assessment was done. So it's not, the report didn't make that issue, the executive aware about this issue.
But you didn't see that it was serious, sort of like the Gardaí have obviously had to be referred in now to the situation you're talking about.
Yeah,
so there's a clear issue of judgment here.
If I may, because I'm focusing on the patient safety and the risk elements, because they were our priorities, keeping the patients at the front and fore of our minds. So the issue that was raised actually in relation to the risk was around what we'd call a single point of failure, where there's a single clinician involved in a what we call a tertiary service. That was brought up through the appropriate elements of the HSE, and thankfully they totally supported us in actually investment in 2021, very early in 2021, even before the report was finalised. So there was issues and matters that were coming up through our processes that weren't just revealed in this report, they were being managed. And I can report then to say that that they also, most importantly, is some of the HR processes, because they were historical, they were there for years, and they were actually addressed as well. And finally, I think the training issue we took very seriously, and actually went with the training bodies and went with the external review of how training is actually assessed. We were very open about all of those in 2021, they were addressed. But the staff did feel, and we wanted them to be open and honest, they did feel these were long-standing issues, and they wanted them to be brought to our attention, and that, and I'm glad they did that, and we said very clearly at the time that if you raise it, we will take action and we will address it, and I absolutely action was taken, and we did report specific issues up through the HSE, through the relevant process, through our normal process, but we did not disclose the report, as Ms Nugent has outlined why.
Okay, thank you, Ms Hart. To the HSE, are you satisfied now that those I think they may be characterised as historic issues by Ms Hardiman, because there's a belief that all those issues have been resolved. Are you satisfied that all those issues are resolved? Like, we have a HICWA report from this year which sets out fundamental reforms to address another department, but I want to hear from yourselves as to whether you believe those measures taken, as Ms Hardiman is suggesting, has now effectively removed that risk to patients and indeed those challenging behaviours that were referred to.
So just in terms of the series of issues that people have mentioned here today that are presenting in CHI, the Health Service Executive, in consultation with CHI, have initiated a process under the service arrangement to include enhanced governance and oversight at CHI. And the CEO has put in place a national oversight group that CHI are a member of to go through all of those issues and to have a robust governance around all of those issues to ensure there's an enhanced assurance process from the HSE's perspective, but also to support Ms Nugent in the job and the tasks ahead.
But it's happening as opposed to it's completed.
That process is in situ at this point.
That's fine. Can I just clarify with regards to the Dixon report? Am I correct in saying that you said earlier that the CHI does not accept the recommendations of the Dixon report? Just very, very quickly.
Very quickly, this was pre-CHI. It was a Temple Street report.
But are you accepting? Did you say you don't accept the Dixon report, or you do?
No, because Temple Street and Cromwell themselves, at the time, as two independent hospitals, had raised concerns and issues about elements of that report, and it wasn't actually processed. I have to say, though, Deputy Sherlock, it did identify there was need for investment and all of these, which were quite obvious, but there was other elements of it that actually were caused problematic that between the clinicians, and hence it wasn't able to be progressed.
So just to be clear, that there was an email from your office, right, in October 2019, when you were Chief Executive of CHI, to the Spina Bifida Hydrocephalus Paediatric Advocacy Committee, which stated, the registry for children with spina bifida across CHI is currently being validated at consultant level. We are also recommending the recommendations of an external review of urology service, brackets Dixon report, which includes spina bifida care. Now, there seems to be a disconnect between what was in that correspondence and what has been communicated today. We could talk all day about those issues, but I do want to move on. With regards to the bullying that took place, Ms Nugent, obviously very significant implications there in terms of high attrition of support staff. The specialist registrar scheme had to be suspended. What actions have been taken from a HR perspective? Have people been suspended? Like, bullying is a serious allegation. So what HR actions have been taken?
So when the report was finalised, everyone agreed that there needed to be an intervention because it was unacceptable. So there was an external facilitator who worked with the team, and the appropriate HR processes were followed in that regard.
Okay, so but there was to be no suspensions or anything like that because of a bullying allegation?
Obviously, as a confidential process, I can't comment further.
So I just need to ask, there's a whole series of questions about the waiting list, but I do want to ask about staffing and the National Children's Hospital. I understand that there's been a long-standing call of the National Children's Hospital to the HSE with regards to staffing. Can you give me the up-to-date figure of what the staffing need is to ensure that you have the current or maintain existing level of services when you move into the new building next year? What is that number?
And just very briefly, because we're over time.
So we've had an extensive engagement, and it's still ongoing between the HSE and the department and ourselves, because there is exciting additionality coming with the new Children's Hospital.
Yes.
So we're still discussing that.
But what is the number? Because I have a number of 382.8 whole-time equivalents that you requested 3 years ago. What is the number now?
It is higher than that.
Can you give me
it
the number?
It hasn't been agreed yet.
No, but can you give us the number? Because we need to understand, we want to support you in making sure that you get the staffing to ensure that we have the services up and running when you move into the hospital next year.
You're over time now. Do you have a number to give us, Ms Nugent?
It's 576.
Thank you very much.
Thank you.
So, deputies, we have just 30 minutes left. We have a hard deadline because the Traveller Committee is sitting in the same room at 12:30 and we need to vacate. So we have a number of members remaining. So I'm proposing to take Senator Ryan, Senator Clonan, and then we have a Fine Gael slot left. Senator Boyle has been here, but he had offered the time to Deputy Brennan, if that's agreeable, as the final remaining 3 slots. Are members,
as long as we get the full 10 minutes.
But are members agreeable to this? I know that's the intention.
I do apologise. I was here up to that.
Do you want to take the remaining? No, sorry.
Yeah. I have questions
we only have.
as well.
Sorry, we only have. We have remaining members here to come in. So we want to get to all the members who are here to get in. No, nobody's spoken for will get in. Unfortunately, we're struggling to get to all the members in the time remaining. But all the members won't have gotten in. So there will be one more Fine Gael slot if you want to decide between yourselves in terms of who can take that one.
Can we split the time?
Yeah, they can share time.
Yeah.
But it's Senator Boyle. Senator Ryan.
Yeah, I'm going to go back to the novel procedures, okay? Because the waffle around it wasn't acceptable, in my opinion, okay? Because you're sitting here and telling us that you can't publish a report because you're worried about naming people, yet you cannot give us a straight answer whether or not the parents were given, were they notified? Did they give consent? Did they know that it was novel procedures that they were signing up to?
The word novel, I can understand, can provide some concern, okay? My previous statement was of how accepted procedures get modified over time.
Yeah, and we know
so
that.
So it was assault osteotomy.
We're aware of how that works, yeah.
In relation to whether parents were told that or not, I can't honestly say, I don't know.
Okay, so you don't know. Okay, that's fine. Moving on, you had mentioned that there was no clinical ethics process in place, okay? Why is it only now in place? Because you're not running a corner shop. You're working with children in a hospital, okay? Where was that before this?
Well, there was always a research and ethics committee in place. So this is an enhanced committee specifically to look at.
Okay, so and what had they done during that time? Why is there a massive need now for an enhanced one? What was their role in the first place?
I think, again, when we have procedures, drugs, devices that are not normally used in paediatrics, we have to have a process in place to make sure that we are operating in an ethical manner and in the best interests of the child.
Yes, we know that, but we know also that didn't happen.
Sorry, my colleague Dr. Goldman wants to get in.
We know that didn't happen here either, right? So, yeah, what's...
So thank you, really important question. We always had a research ethics committee for research studies, and like many other big children's hospitals in the world, a clinical ethics committee that goes with that is very important. And our clinical ethics committee has two key roles. So the first role is discussions about children where there are challenges around the care. And that gives parents an opportunity to come in and present that, and it gives
Perfect.
the team
And
a
did
discussion.
this committee
So
flag
that's,
this?
yeah, so that's the
with
first component of that committee.
Yeah.
And then the second component, which we've added on, is to cover novel procedures, because
So why was this clinical committee that was already there not flag the novel procedures initially when this was happening? Why do you need to put in a second one?
no, we haven't put this clinical committee, the clinical ethics committee. It's been up and running between 1 and 1.5 years. I could get the date for you. So we only set it up at that time. We didn't have a clinical ethics committee at the time.
Okay, why not?
I can't say I started here in 2021. That was one of the ambitions to set up that, and it took a little
why
while
was
to
that
set
not
up.
set up?
Yeah, I can actually, but that was one of the things that when the Chief Medical Officer, Dr. Goldman, came on board, was to actually progress this element. Before that, we had a process whereby the Research and Ethics Committee actually did take some elements that were relating to clinical ethics. We also have a clinical ethicist in Children's Health Ireland, and if there were issues of that nature that needed to be discussed, there was a group that would come together. What Dr. Goldman has put in place is meant that, as opposed to responding to issues when they were formally raised, is to put it into a more formal process. So there was a form of ethics support for staff that raised those particular issues before this put up in a formal committee.
Okay. Now, Ms. Digent, I know you're new to the role, but we have seen how the word, what's that word? Jesus, there's so many things going on through my head. But the word culture is used as a scapegoat, especially in medical professionals, right? We've seen it like culture, we need to change the culture, and that's the issue. But how are you going to change the culture when the core is rotten? Because it starts from the core and feeds out. You mentioned that there is, the staff are brilliant, they're doing the work, they've mechanisms to raise issues, we want to hear about the issues, but what it sounds to me like is that management didn't do nothing about the issues when they were raised from the staff, right? So how are you fixing that culture? Because it's not going to happen overnight.
No, it won't happen overnight, but it's key for the success of the organisation. So there are a number of programmes we're doing, but also I'm trying to get out and about. I do town halls where I stand up in front of the staff and they can ask me any question, and they are raising issues. And we are...
Are you willing to do that for parents?
Yeah, I am.
Are you willing to do those meetings for parents where they can
Yeah.
stand up and ask you those questions directly themselves?
Yeah.
Perfect. Now, I do have a question for Dr. Moore. So, Dr. Moore, you had said recently in The Sun that, this is around the funding, okay? So you had said, I had no act or part in the 19 million, but my understanding is that every single penny was used in CHI, right? As a national clinical lead in first spinal surgery, can you explain how you had no act in this whatsoever in the allocation or the oversight of the 19 million?
So my understanding is my role started just over a year ago in February of 2024. I wasn't in that position. I am aware of the 19 million because there was a HSE audit of it, and my understanding is they validated the use of those funds in CHI. That's, I can't really comment any further.
Okay, then I'll go to the HSE.
Thank you. So again, my understanding is the same as Dr. Moore's in that audit was commissioned by by the HSE, and it was found to be that the funding was used for inappropriate way.
Okay, and so CHI, who had the oversight of that funding? Where was that funding oversighted? How was it spent?
Funding comes in through the HSE. It goes through an internal process. It comes in through Rosetta. It's a financial system, and then obviously it is tracked. There's a tracker for how. So if it's, for example, if it's for posts, there's a tracker system then for when those posts were advertised, filled, and we only actually get the money for those posts when you fill them, and we have a process. Then we go back to the HSE and say, this post is filled. Can we have the money, please? So I know you have a tracker in the spinal unit itself, because obviously we have had a lot of welcome investment in the spinal unit in relation to staffing. So we're very grateful for that, but there is a robust process. We only get the money when we have the post filled.
So what it sounds like around here at the moment is that it's the accountability piece, as Senator Costello had mentioned. Nobody seems to be accountable for anything right now. It seems to be pass the book around, we'll see who's, you know.
Senator, I'm the accountable officer of CHI. I apologise if I don't have all the answers because I am still new in my role, but I am the accountable officer.
And that's fine, but, you know, people need answers to the questions that they have. And while the sorries are welcome, there are parents and there are children who are worried at their wit's end at the moment in time. They don't know what's going to happen. They're sitting in the dark, and we're sitting here saying, oh, the culture is going to change. We're going to fix the culture and that should be better. That's not good enough. It really is not good enough. It's not what people need to hear right now. It's not what people want. They've been let down, and this is the reality of what we're seeing now, okay? So, like, saying the culture is going to change and this, that, the other, and passing the book around, no one's been held accountable yet. And that's a real concern for people. Ms Hardiman had bypassed that question that Senator Costello had asked. What sanctions did you get? Nothing.
Well, no, but
nothing.
But
because you're still sitting here.
If I may, like, part of the accountability here is been here today, and actually answering the questions to the best of my ability, and I'm happy to do that, and to any of the obviously Oireachtas committees as a public servant. I accept that there were weaknesses. I've apologised for those particular weaknesses. And there also is, I think, put in structures and processes that we've tried to actually address them. So the recommendations are being implemented by the actions. There is a lot of work to be done. It wasn't all perfect, absolutely not. But there was a, you know, there was a lot of challenges actually in relation to merging hospitals. There's a lot of challenges, and we as a new entity, 2 of our first years were very unusual, to be quite honest, with the pandemic and a cyber attack that actually that brought on greater stresses to try and get what we were trying to do, and are definitely in a better space now, is that integration and standardisation and that single governance process. Because we did have hospitals in certainly the early parts of CHI, because we set it up that way, where they had to move from being hospital-centric to hospital site orientated to being single, and that is quite complex, and it takes time to actually
And I understand
make
that and I appreciate that, but if I was in a job and if I was sitting in a position and I didn't do my job diligently, I wouldn't be sitting here right in front of you now.
So members, we have 2 remaining 10-minute slots left to take. This Fine Gael representatives haven't spoken, are going to share the time, and we've Senator Clonan as well. So, do you want to, we'll have Senator Clonan to go?
Sorry?
We have 2 slots remaining, so Senator Byrne, yeah, we're going to take it. Deputy Brennan, so taking it.
Thank you very much for your time. I'm sitting here as a TD, but I'm also sitting here as a parent who's affected by this. That's why I purposely sat with these people behind me for the very first phase of this morning, as a parent. My story, I went to Kappa with my young child who had an previously underlying health condition, and we sat in front of the surgeon that is on leave, and we were told that we should seriously consider surgery. I asked for the pros and cons like any other parent would. We left, we drove back to Wexford. There was hardly a word said between myself and my wife in the car. But as we drove into our house, I turned to my wife and said, we can proceed. My young son had gone through enough, so it's with the grace of God, I'm not sitting there. It is absolutely horrific. I'm strong. People say, do you think about it every day? I don't, but what I do think about every day is the parents. My God, how did this happen? I'm of the very, very firm opinion that justice must take its course. But in my opinion, if this plays out the way I think it may play out, this could be one of the biggest medical malpractices in the history of the state. And with all due respect to the people that are sitting in front of us here this morning, let's call this out as it is. The people sitting in front of me now were in the driving seat when this is going on. It was under your watch. Those are the facts. How was this allowed to happen? How can a surgeon, I heard the comments early on, they may be tired, overworked and all that, and I don't want to turn any surgeon, and I repeat, let justice take its course. But how can a parent hand their young child over to a surgeon? It's the most vulnerable person in our society, our children. You hand it to a surgeon, you presume and expect and demand that they get the full care they deserve. And it is very clear that this did not happen. And this is so wrong. It really is. I'm conscious of time, but there's three main factors here. Number one is the family. When I speak about the family, I speak about the parents and the child. I'm very conscious of the work that's been done by our minister to ensure that things are improving. But there was a full policy of exclusion for these people behind me. Why were they excluded? That has to change, and I can see it is changing, to inclusion. They must be part of every part of this process. They must be fully engaged with everything that's going on in the future. That is not a request. That is a demand from a parent. As I say, I'm lucky. I am lucky. Bar my young lad and that child now is out there running nearly, he's only 7 years of age, he's running nearly half marathons. You know, thank God he's in that position. But every day I think of these parents. Prevention. How can you honestly say this will never happen again? Because based on what I've heard this morning, I feel that is not the case. And that is essential that the minister is taking the lead on this, but it's essential that we have to get processes, that this can never happen again.
Senator Boyle.
Last one is justice. Justice has to play out. If somebody has done something wrong, they must stand up and be accountable. You cannot go under CHI have taken responsibility, but the individual that stood over their children has to take responsibility. Thank you for your time.
Just well done, said to my colleague here, Deputy Brennan, alongside me. I just want to ask, did HICWA consult any hip preservation surgeons prior to publishing the recent report which failed to recommend universal screening for dysplasia? And I suppose, why has universal screening not been adopted? Because certainly it is used, I know, in a lot of other countries, and it's a preservation. In other words, it shows whether a person actually needs the procedure or not. And why did CHI preservation surgeries in Temple Street and Kappa and compare it to Crumlin, where there is no such service because they outsource it to the Beacon Kids and Galway, which were excluded from the report? So maybe they're my first two questions, please.
Okay, Senator, thank you for that. In relation to the issue of universal screening and the HICWA assessment of that, I would have to defer to my HSE colleagues, as it's a national issue.
Thank you, Deputy. HICWA did conduct HTA, as we call it, of universal screening. It applies, I think, in 2 of the 17 countries they looked at. And what they advised was a more targeted screening programme, because as a screening programme has to demonstrate as part of any evaluation a value for money if you're going to apply it at scale. And that targeted screening programme will be identifying children at risk at birth, those with a family history of dysplasia and those who had a breech delivery. We have short establishing a full screening programme, and we're trying to finalise a proposal for that. We have established a service in 16 centres with ultrasound scans and assessment at 6 weeks for children in those risk groups. And the numbers that are going through that service correspond to the kind of numbers you'd expect to see in those risk groups. But it does need to we would like to see this transform into a fuller screening service. Of course, the ultimate determinant of that is the National Screening Advisory Committee that sits within the Department of Health. But certainly we'll be making a case.
Okay, thank you.
In relation to your question regarding the cases that happened in Galway and in the Beacon Hospital, I understand that there was a retirement in Galway of a surgeon who did these procedures. They were supported by colleagues in Crumlin until a new consultant could be appointed. As you're aware, the Crumlin consultants are compliant with the criteria for DDH surgery. And in relation to the Beacon cases, I'm not familiar with them, but I understand they were done under a charitable process, and again an audit was taken to ensure that they were compliant. They were Crumlin surgeons.
Okay, and I suppose will CHI now audit infants discharged from clinic with a single normal tubular index in light of the fact that one such measurement does not exclude development of hip dysplasia? So
I think I might have to defer to my colleague on that one.
Great, thank you.
So we tend to look at the trend of what the x-rays look like. It depends on the risk factors and the original diagnosis. If the hip was dislocated, very underdeveloped, you'll keep an eye on them longer. You won't just take one measurement. If it has never really been a concern and it was just kind of somebody thought there was something there, then you might discharge them with one x-ray measurement if it's normal, obviously.
And I suppose in terms of the leaked report, maybe just a comment in relation to that, because it has upset so many families and so many people. And I know you referred to that CEO, but I suppose I really do believe the families deserve an apology, but also maybe the surgeons and the staff that were involved as well. So just a comment in relation to that.
So the most important thing was that the patients identified in relation to time waiting, they were all reviewed, redisputed, dated and had their treatment. In relation to the staff involved, I've met them. By their own admission, they are a better functioning team than they were prior to that intervention. So that is a positive. But actually, they're still engaging with supports to make sure that they can build themselves up to be a well-functioning team in advance of the New Children's Hospital, which is a focus for us right across the organisation.
Thank you. And just one final thing is, my understanding is from reports that Ireland has the highest amount of total hip replacements, and maybe you'd like to comment on that in relation to, I suppose, experiences elsewhere.
Just very briefly as well, because we've one more speaker.
I'm not aware of what, where you're getting that information. It may be correct. I didn't know we were the world leaders, if you want to put it that way, in hip replacement surgery. I can't comment on that really.
I suppose it's outside of CHI's paediatric service, I suppose. Not
One more final remaining speaker, Deputy or Senator Clonan, for 10 minutes.
And I think the challenge I'm going to have is not to get emotional during this. And I want to say before I ask you your questions, there's nothing personal in this. I know that each and every person here is a good person who's trying to do their best. But collectively, ladies and gentlemen, something has gone terribly wrong. And it is a scandal of international dimensions. So this report, which you haven't published, is absolutely shocking. My son had spinal surgery in Temple Street in 2018. If I had known about the contents of this report, I would not have given consent. Because this report shows you're operating a three-ring circus with the language that's in this, a toxic, broken culture, abhorrent work practices. And let me be really clear. The rogue consultant narrative that you're relying upon is only a symptom of the problem. And it is stated over and over again in this report. The problem lies with the senior leadership team, executive and board. You are the problem. And you must take collective responsibility for that. And that's my first question. Will you take collective responsibility for that? And in the conclusion of the report, it says a substantial and persistent message of concern over apathy regarding the lack of management, leadership and good governance, along with poor operational oversight and accountability, came through very strongly during this examination. There is a lack of trust in leadership in being able to adequately challenge and address the issues raised in this report, which you are refusing to release. So my next question is for you, Dr. Henry, and I'm sorry to have to address this to you, but bearing in mind the contents of this and these conclusions, do you have confidence in the senior leadership team and the board who have presided over all of this harm to transition 3 children's hospitals into CHI? Because I don't. I would not allow my child to be treated in the environment that's set out and described. And I am not, I'm sorry to say, I'm not at all reassured by your responses. Sorry doesn't cut it. And when I was in with this committee, Dr. Goldman and Dr. Okafor, and I described the circumstances of my son's surgery and how late it was and how traumatising and unnecessarily so it was, you were aware of all of this and you did not inform the committee of the risk factors that were there. So I'm not convinced that you're fully open and that you're invested in open disclosure. It's clearly not the case. So there's 2 questions there. Do you accept responsibility for this? And I don't want an apology. I'm not finished. Sorry, Ms. Nugent, I beg your pardon. And then, do you have confidence, having heard what's in these reports, for this? I mean, if you were running Tato Park, I wouldn't let my children go there. It's as frank as that. Who is doing your public relations and crisis communications? What company does CHI employ to do your crisis comms and your public affairs and your public relations? And how much of our taxpayers' money are you paying them? I have a few more questions. In this report, there is a very alarming issue around the urological waitlist. And there's a cohort of patients known as the Crumlin orphans who are not receiving treatment from a urological surgeon with higher specialist training for the transitional pathway treatments that they need. That is absolutely extraordinary. These are children who need surgical procedures that are routine in other jurisdictions on their little penises, on the reproductive organs of teenage girls and teenage boys. How many, now those children, according to the report, are reaching the transitional pathway to adult services. How many of those children have become infertile due to a lack of surgical intervention? Now, if you make a mistake, if you go to the bathroom and you know the way you have 2 switches, one is for the fan and one is for the light, and you accidentally turn on the fan, I meant to turn on the light, that's a mistake. But this is a systematic and systemic failing of these children on the urology waitlist. And I raised this last year in the Shannon. In January, I raised it several times, and the Minister refused to come into the Shannon for my commencements. And it was reported by some of our journalist colleagues here. I am absolutely shocked to think that we have de facto sterilisation of disabled children in this country. That's shameful, and that is an international scandal of proportions that I struggle to find the vocabulary to describe that. So you tell me how many children have become infertile whose reproductive capacities are compromised for a lack of timely surgical intervention. The other question I have is in relation to other reports that are buried and that have not been published. If you could give an undertaking to furnish me with the Dixon report, please, by way of the committee. I'm not finished. And those other reports that you mentioned. Because how can I give, or how can any of the parents here give informed consent for their children to be treated by you if they don't have the full facts about the actual circumstances and the risk factors that you preside over? And let me be clear. You as a board and as a senior leadership team, and you're very highly remunerated, and you've competed to be in those positions. You can delegate authority, but you cannot delegate responsibility. You are responsible personally, individually, and collectively for everything that happens or fails to happen on your watch. And saying it was like that when I got here is not a defence.
Senator, the witness will need time to respond to that.
Thank you.
So, in relation to accountability, yes, thank you. I do accept accountability, as I said.
No, responsibility.
And responsibility.
So what are you going to do? How are you going to discharge that responsibility? Just carry on?
No, and that is why I have reconfigured our executive structures, and that goes right down from executive level to clinical director level to clinical specialty level, so that we can actually ensure that we are, number one, measuring the right things, and it's not about outputs, it's about outcomes. That we are actually, there are issues that we deal with them quickly and head on.
So again, like this report, I never hear the word children or parents. I hear measurements, quantitative stats, this, that and the other. If we could move on to the other questions, who's doing your PR?
We actually manage our crisis management, etc. internally. We have a communications department. We have a Q4 company on retainer monthly. So, for example, we would have had a session with them to prepare for ourselves today.
Yeah, and how much are you paying them?
It's, I don't know the exact figure off the top of my head. I have to come back to you.
Will you send that to the committee? Because the rogue consultant narrative, you're getting value for money, I have to say. I say that with, you know, I'm very disappointed to see that narrative being, I mean, absolutely, this is a systemic and systematic failure at board and executive level, and you're not fit for purpose. And I am very alarmed that you retain, that you purport having, you know, what we know, that you purport to be trusted to transition into CHI. I think that's going to be a major risk event, and I trust that. I'm glad to see that the HSE have intervened and stepped in, because you know this needs oversight and needs to be very carefully managed, because it's harm to children that we're talking about. And again, very quickly, I don't know, Dr. Goldman or Dr. Okafor, can you tell me how many children have become infertile due to a lack of timely intervention in the urological pathway?
Dr. Goldman will answer that.
I'm not aware. It's impossible to say.
So you don't know. Wow. You don't know. And you do know that, and I know, Dr. Okafor, that you know the consequences and the implications of children not receiving timely intervention on the urological pathway. So you don't know. What do the parents think of that? That is shocking. Shocking. Because I have highlighted this in these houses of the Oireachtas on behalf of the people who've elected me here, who've given me a mandate. We have put this down on the record. I have all of my contributions here, at least a half a dozen contributions, where I warned about the lack of surgical interventions on the urological pathway, which is routine in other jurisdictions. And Dr. Goldman, as I said to you the last time, you come from Great Ormond Street. Are you not shocked at what you find here in this republic in terms of the suboptimal outcomes for children in CHI?
Just 30 seconds remaining.
Look, Senator, thank you for your questions. I came here from Great Ormond Street with huge optimism about the prospects of the new hospital and bringing everything together. As issues arose, and many were legacy, we instituted as open as we could reviews.
Yeah, this word legacy has been used repeatedly, but you don't know how many of our children have become infertile due to a lack of timely intervention. And again, it's like the light in the switch fan. That's not a mistake. That is an ongoing, systemic and systematic failure of our children. Disabled children being de facto sterilised for lack of intervention on your watch, and you don't even know.
Thank you, Senator. Sorry, we're actually out of time on that slot. What I would say is there's a number of unanswered questions there, and I would ask maybe the witnesses might write to the committee to answer some of the questions we didn't get answers to, if that's agreeable.
Certainly. I mean, if you like, Dr. Goldman could give some feedback on the issue that Dr. Clune has raised, because we did actually look at scientific evidence, consult with the urologists, etc.
We will, and I think the committee will agree that we will engage again in the near future with you on this and to get answers to some of the other questions. So I'd like to thank CHI, the HSE, the Department of Health for an engagement with the committee on this issue. And as I say, the committee remains concerned about the serious issues, and we'll consider it further. And as I say, I expect we'll be in touch again. So now we will adjourn the session. Next meeting in public session is a meeting of the Select Committee with the Minister for Health, Jennifer Carr-McNeill, to consider the estimates for public services for 2025 and vote 38 of health. The joint committee's next meeting, public session, is Wednesday, the 2nd of July 2025. Can we put order, please? Order. The next meeting, it has been agreed that the Joint Committee will meet in private session at 3:15 on Tuesday, 24th of June on MS Teams to consider correspondence and other committee matters. Adjourned.